I'm gonna work out to speak.
Good afternoon, and welcome to the Black Health Trust Weekly Program. My name is Michelle, and I'm your host here to introduce and assist with today's programming. We're so pleased that you've chosen to empower yourselves today by joining us. As always, Black Health Trust is grateful to have its regular and faithful attendees back and those new to the program. So thank you for being here. Today, our discussion topic is COVID-19 updates, what you need to know now. The panel will be moderated by the distinguished Dr. Randall Maxey, Chief Medical Officer of Advanced Community Medical Care Corporation in Los Angeles and President and Founder of the Black Health Trust. Dr. Maxey will introduce his distinguished co-moderators, Dr. Barbara Nabert-Stevens and Dr. Ivan Walks, who will then introduce our guest panel today. Black Health Trust was founded in response to the coronavirus's the global pandemic and Dr. Randall Maxey's personal and urgent desire to keep his own family safe. Fortunately for us, his commitment to collectively informing his tribe evolved into a much larger vision for the community. The purpose and mission of the Black Health Trust is to provide credible insights from our community health experts to best serve our communities of color with a coalition of leading and long-standing Black medical professionals across a diverse spectrum of disciplines and to offer their expertise and insights into our physical and mental health during these challenging times. These opinions are also offered to help educate and inspire you to take your health seriously and to ask questions of your own medical practitioners. I will ask everyone to mute their devices at this moment so I can continue. So now I'll read the disclaimer. Please note that the information communicated on this program is not intended or deemed to be medical or legal advice. And you should always consult your own medical or legal professional for advice and direction pertaining to your particular situation and needs. The information presented here is not advice, but rather opinions and recommendations from credible sources. Black Health Trust, its representatives, members, employees, attendees, heirs, assigns, and guest speakers and presenters assume no liability whatsoever in connection with the information presented or used by anyone, nor are these discussions directed to specific situations. Again, we strongly encourage all attendees of this program to consult your own legal or medical professional for conclusive guidance on how to proceed in your own personal circumstances. So now I'll just share a few housekeeping items and announcements. This program is live and it's being recorded right now on different public programs like Facebook Live and YouTube. By your voluntary attendance here, you understand that if you choose to participate and prefer not to have your image and likeness displayed, there are visual and audio settings on your personal device that you can control to block your picture and mute your voice throughout the program at any time. That said, all participants are to be muted by our Zoom technician initially, and we ask that you remain so until the host or moderator asks you to contribute. So thank you very much for that. With regards to the chat room, for all of our participants, we ask that if you have questions, and we hope you will, you enter them into the chat room. Please limit your questions to 2 per topic being addressed, and please do not use the forum to advertise or promote your products. Understand that there may not be sufficient time to get to all questions. Please don't take it personally. We'll just do our best with the time we have allotted. So thank you for that. So we are still in this together. If this program has been and is valuable and interesting to you, please visit the website to learn more about our programming and so much more that BHT now has to offer. And you can support us by going to blackhealthtrust.org so we can continue bringing our community outstanding content. We need your support. blackhealthtrust.org. We thank you, Black Health Trust Steering Committee, Executive Board, our virtual administrative assistant, we couldn't do this without you, our media, production, and Zoom technician, BHT supporters, and all the people behind the scenes for their time and efforts that make this programming possible. Let's now welcome all of our distinguished physicians and special guests. We thank you for sharing your valuable time, your information, and educated insights with us today. Your participation and support help to continue to empower our communities of color, and this is so critical to our present and future well-being as a people. As you know, Black is beautiful and knowledge is power. Welcome again, everyone, to the Black Health Trust weekly program. This is our community. This is our time to take care of our health. Grab your coffee, tea, get comfortable, lean in. Dr. Maxey, please do us the honor of beginning today's program.
Thank you so much, Michelle. I appreciate everybody joining us today. Our regular guests, our community, our distinguished speakers, and my co-host and moderator, Dr. Barbara Nabert-Stevens, and Dr. Ivan Walks. My watchword for today is common sense. But common sense sometimes is not quite as common as it should be. And I told a nephew of mine who's on the phone that I was going to use him as a foil, but he said he's coming to LA, so I'm going to think differently of that. And I use myself, but a few years ago, and I need to preface this with saying that I am both an MD and a PhD, but I noticed I had a problem with my eyesight. And I kept putting it off. And really in the back of my mind, I figured that if I didn't go and see the doctor, I wouldn't have a diagnosis. Well, as it turned out, certain people said that was a really negligent on my part. And as a result of my personal negligence to my own situation, I suffered significant damage to my great and valuable eyesight. Some people would even say that I was trifling in a way. And the reason I speak to this, that we have so many of our people who have been afraid of vaccines, who have had misinformation. Some people have talked about vaccine hesitancy. Certain people have just not wanted to go get a diagnosis or see a doctor. And we're here to tell you that you should take care of yourself. I had a lady who was very close to me, in fact, the first lady of my church, who refused out of fear to get her required testing, mammograms, and other issues. And when we finally picked up a symptom of shortness of breath, she had stage 4 breast cancer, metastatic, and she died within 2 weeks of that. So what am I saying? Let's use common sense. We've got all sorts of guidelines and directives. We know that those of us who are older are especially at risk, but we know the younger people are at risk. We need to use common sense and take care of yourself. There were things killing us long before COVID, and they're still there. They don't go away with COVID. We need to get checked. So my word for the day is common sense. I take great pleasure in introducing both Dr. Barbara Navert-Stevens, who is a pediatrician and former administrator at Meharry Medical School, and also Dr. Ivan Walks. I let them briefly introduce us, and I'd like to get right to our first speaker. We have some time constraints on that. Dr. Barbara Navert-Stevens, would you introduce Dr. Walks and vice versa?
It is my pleasure, as always, to introduce my co-moderator, Dr. Ivan Walks. Dr. Walks is a psychiatrist by training, and it is very helpful that he has that skill set, because we're in a time where we need to pull together and pull on all of the senses and capacities that we have to not only survive, but thrive. He's eminently qualified and trained, having had his undergraduate training in California and then moving to DC, where he has had a very illustrious career as a public health servant, working as Chief Public Health Officer for the District of Columbia, as well as providing expertise and counsel to our president, at least 2 of our presidents. And I wouldn't be at all surprised if he doesn't have that opportunity to do it again. He's currently the founder of Walks Associates and actively sees patients, as well as pursuing whatever he can do to help move us forward during these very difficult times. Dr. Walks.
Thank you, Dr. Neighbor Stevens. You are so kind, and I certainly appreciate the kind words. And my mom especially likes to hear people talk about how smart I am. I'm okay whether it happens or not, but my mom loves it. So thank you. If we can put Dr. Neighbor Stevens' slide up, I have some things to say about Barbara Neighbor Stevens. Anytime part of your story includes graduate of Harvard University and Tufts Medical School, we know we are dealing with someone who is super smart and has perseverance. And those are two things that Dr. Neighbor Stevens brings to the Black Health Trust. As Dr. Maxey said, she has been a senior administrator at Meharry and also a senior leader in the National Medical Association, as have many of the folks who work with the Black Health Trust, Dr. Maxey, Dr. Dennis, other folks who regularly work with us. And that demonstrated interest in policy in our community is something that Dr. Neighbor Stevens brings to the Black Health Trust that I think is critically important. She's also worked on, you may say, both sides of the aisle, meaning the academic side as well as the side that takes us out into the community. And I think that ability to look at policy and make sure that the academic side as well as the clinical side is served is a very useful thing as we try to bring good health information and good health behavior to our community. So Dr. Neighbor Stevens, Dr. Maxey, it's an honor to be with both of you all the time, as well as with all of the other amazing people that come to the Black Health Trust. So I will toss it back to my colleague and mentor and friend, Dr. Neighbor Stevens.
Thank you. It is now time for me to review our weekly statistics. If you could put those slides up, please. As you know, we use the data provided by the CDC, which is updated the night before. So this is from yesterday. As of yesterday, last evening, they report a total of 32,722,464 cases have occurred in the United States since the beginning of the pandemic last January. We had a total new daily caseload of 37,314, which is down some from the high when we were at our surge, but I emphasize it's still a lot. Our total US deaths have continued to grow, not quite as fast as they were. We are now at 582,263. It was just over about a month ago now. Time kind of flies. At least I'm finding that it's flying, that we were approaching the 500,000 mark, and we're now coming up on the 600,000 mark. Yesterday, 690 deaths were reported around the country, which is significantly lower. Our total vaccine dose administration is reported to be at 270,832,342. That's a combination of individuals having received just the first of two, as well as those having completed the series of either 2 and 1, depending on the product. Next slide, please. I want to spend a little more time today. I normally just kind of fly through this one, but I want to spend a little more time on this today because it's going to help set the platform from which I hope we jump in our conversations today. This is limited data because they don't have access to all of the data in the United States, because unfortunately, this country has not moved to a point where we universally report demographic information. So that's why there's discrepancy between these numbers and the numbers that I mentioned a minute ago. But based on the data that the CDC has consistently been able to collect, you will notice that the African American population has a 12.4% penetration of vaccine administration, and that's either one or completed series. Now, that is 12.4% of the total African American population. I want to make that clear. It's not 12.4% of the total population. If you look at the number of African Americans that have received vaccine, it is only 8.8% of the total population. And I want to drive home that point. As I said, the CDC has limited ways of reporting based on the way the states report. But the Kaiser Family Foundation has been looking at state level data and monitoring things during the course of the pandemic. And they report that 40% of the total population, 40% of the white population, let me be very specific, has received some level of vaccination, whereas only 27% of the African American population has received some level of vaccination, which means then that there are 1.5 times more white vaccinations have occurred across the states than African American vaccinations. The reason I am really pushing on this today is because we're going to be talking about the new mask guidelines, which are hinged on whether or not you are vaccinated or not. And I'm not going to steal the thunder from the rest of the broadcast, but I'd want you to keep these statistics in mind because it begs the question, why are we under-vaccinated? There are those who want to say it's because of vaccine confidence issues, which probably is a part of it. And there are those who want to say it's inequitable access, and that's also probably a part of it. But I want to throw out to the program consideration today, I think there's some other issues at play. And unless you understand what your drivers are, your interventions won't get you the results that you're shooting for. So I want us to have an honest discussion today about what's going on in our community. And I'll stop at that.
Let us introduce Dr. Kane.
Would you like for me to introduce Dr. Kane?
I think you know her rather well. That would be great.
It is my pleasure to present my sister, Dr. Virginia Kane. She is not a stranger to our group. She has been with us before and has been a background supporter in more ways than you'll ever know. Dr. Kane is a distinguished internist and infectious disease specialist, well renowned in this country. She is the director of the Marion County Public Health Department, which for those of you who don't know, state level departments of health, that's Indianapolis. And she is an associate professor at Indiana University School of Medicine. Now, just so that you get a sense of how well-rounded Dr. Kane is, I've sort of hinted at her academic and specialty credentials, but because of her role, Dr. Kane has to make decisions about the basketball tournaments, the big tournaments that happen in Indianapolis. She has to make decisions about the Indianapolis 400 race coming up.
It's 500 now, 500. We've grown.
Thank you, Dr. Kane, the 500. So, we have influence in a lot of things that people don't realize. And I just wanted to bring that up. She has served as president of the American Public Health Association. She has been hard at work in the vineyards at National Medical Association, supporting the internal medicine section and serving as former chair of the board. And she is well known throughout the country in terms of her expertise. So without further ado, I'd like to turn the program over to Dr. Virginia Kane.
Well, thank you. I was invited to just talk about the new guidelines related to the mask guidelines that have been put out at CDC and how will that impact us. And I'm sorry, I don't have a formal PowerPoint presentation because this just happened on Friday. And but what kind of impact will it have on us related to the recommendations that are made? And I think, as Barbara alluded to the fact that once we open this up, the mask, where now you don't have to wear a mask if you're vaccinated, indoors or outdoors, whether it's a small gathering or a large gathering, this is in the context of us having in every state now what we call those variant mutant strains that appear to be very contagious. And not only are they contagious, but they may be associated with more severe complications as a result of that. And, you know, we first heard about Great Britain as a virulent strain, and which we have now in every state. But then that followed with the South African strain, which was a little bit more virulent and a little bit more resistant to the vaccines that we have in place. And then next, the Brazil/Japanese strain. And for those of you out in California, you know that you have a California variant strain out there. And now with this huge epidemic taking place in India, they now recognize that there's a new strain related to what's happening in India. So what do I mean by this? So in the context of now saying it's safe if you've been fully vaccinated, all the vaccines are not equal in terms of their protection against the virulent strain. And depending on the efficacy of the current vaccines that we have, will it fully protect us from those virulent strains that may be more severe and may be associated with more complications, and especially when we look at our adolescents and young adults, where before they didn't seem to have the same high level of hospitalizations, the high level of deaths now. We're now seeing that some of these virulent strains are having more of a predilection for our adolescents with more severe complications. So I just invite anyone, just tell me now, what do you think with this new mask guidelines? How will it impact people of color? Anyone?
Well,
Dr. King, I'm wondering if I can just ask you for a couple of definitions in your talk. When you use the word efficacy, what does that mean to the layperson? And predilection, what does that mean? And level of infectiousness, can you just break those down as we start to answer your question?
So let me start out with efficacy. Efficacy means how effective is a vaccine in preventing infection. So when we look at the Pfizer vaccine and we look at the Moderna vaccine, it has about what we consider it is 95% effective in preventing COVID-19 infection, or if you get the infection, it makes it a much more milder infection if you should contract COVID-19, because these vaccines build up antibodies in your body that specifically targets COVID-19 viruses in your body. And because it's attacking it and killing it, if you're exposed to some of the COVID-19, you don't get sick enough a lot of times to be hospitalized or to get into a critical care unit where you are placed on a respirator and you're at extremely high risk for dying. And so the Pfizer Moderna has a 95% effectiveness. That means it doesn't work on about 5% of the population for whatever reason. And the Johnson & Johnson vaccine is supposed to have a 66% effectiveness. But let me just say this. At the time the Johnson & Johnson trials took place, it was a considerable amount of months, way later than when the Pfizer and Moderna vaccine trials took place. So what I'm saying here is when the Johnson & Johnson trials took place, these trials were primarily more against people who had a significant number of virulent strains that were more difficult to treat. So your Johnson & Johnson vaccine might be just as good as the Pfizer or the Moderna in terms of being effective. Now, when I say predilection, I mean that it means it has a special ability to target a certain person, and certain persons appear to be more susceptible. And so, unfortunately for us, a lot of people of color have not been vaccinated. And so once we open up this huge mandate for the mask, if our African Americans are less vaccinated, then when we have a surge of infections, you're going to see more pockets of Black or African Americans being infected because they're not vaccinated. And because of social determinants, they're more likely to be having frontline jobs, okay, where they're at a higher risk for exposure. They don't have the luxury like we do to maybe telehealth, be at home and do their work over the computer. Or they may be bus drivers, public transportation. So they're exposed to a lot of people in the public. And because of the poverty that we see in our country, we will have a greater number of people living in our apartments or in our houses, and they're intergenerational, so that we have a greater spread for transmission related to wearing these masks. So the vaccine hesitancy or our vaccine confidence in our racial and ethnic populations can have huge negative consequences for people of color, leading to increased morbidity and mortality. And I think you have one last thing you wanted me to.
Virulence.
Virulence means, hey, how deadly is this strain? So is it a mild virulence where it's just mildly severe in causing complications, or is it have great virulence, meaning it has a greater ability to cause more damage or complications in an individual? So one of the scientific words we use is how virulent, how deadly is the strain?
Very good. Dr. Neighbor-Stevens?
I wanted to alert Dr. Kane that the responses to her questions are coming into the chat.
Okay.
And one response that I see is unvaccinated people of color will now be more at risk of becoming ill because the masked people who were previously protecting them will no longer be masked and no longer protecting others. I think that,
yeah. Keep
I think
talking.
that that is a concern that a lot of people have. And I was wondering if you can explain the logic behind the mask guidance when we have less than half of the population vaccinated.
So according to your data, and the most recent data, 47% of Americans, I think it's 155 million Americans, have received at least one dose of vaccination. And we know in the country there's about 320 to 340 million people. So we're 47% vaccinated. But the problem that we're going to have now is that we have a significant number of individuals who feel that it's their individual right, based on the First Amendment, that they should not be required to wear masks. We have a significant number of our religious, faith-based individuals who feel the same way, that they should not be under any mandate or regulations related to wearing masks. So what am I saying here? I'm going to put it in English, that once this mandate comes, you're going to have a lot of people who are not vaccinated, but are not now, will be given the freedom of not having to wear their masks. Based on an honor system, it's unfortunate, but we've already had a number of people who have identified that they were fully vaccinated and they were not. Now, whether it was related, some was related to ignorance, that they fully thought they were fully vaccinated because they got their first shot, and like within 5 days, as soon as they got their first shot, they thought they were fully vaccinated. But we have a significant number of folks, at least in the state of Indiana, who don't feel that they have to have a mask. Some of them feel that this COVID-19 is just a hoax, no matter what you say to them. And that is what's going to put us at risk, because we know at least over 20 to 30% of Hoosiers, that's if you didn't know, that's an Indiana resident, can have no symptoms. They feel great, no fever, nothing's bothering them. So they make the assumption that they're not infected. But those asymptomatic individuals, and there's a high percentage of them, I'm talking about 20, 30, 40%, as many as that, have no symptoms. Just by talking normally to you like I'm doing now, I am putting out invisible respiratory droplets that can last over 30 minutes to hours in the space where I'm talking now. And I can leave. I can leave and go someplace else. Somebody can come in that same space where I had been standing and inhale, and they can contract and become infected with COVID-19, which can have really severe complications if you're immunocompromised. Okay. Maybe you're receiving chemotherapy. Maybe you're an organ transplant person. Maybe you could be have HIV infection, or you could be a young child that's got leukemia or lymphoma. And so it puts us at a much higher risk, as well as individuals who have chronic medical illnesses. So it could be, we would have huge pockets of infection that could occur as a result of this country mandate.
Before I ask Dr. Walks to pose a question or go to the chat box, I just want to ask you to make an analogy. If you were smoking a cigarette, which I know you don't, and you blew out a puff of smoke and then got up and left, that would be the same aerosolization that would be there. And we've all been in places where people have been smoking and they're gone. You still see and in some cases smell that smoke. Is that somewhat the idea?
That's a great analogy. We know that secondhand smoke is significant. It can contribute to sudden infant death syndrome of our babies. And so secondhand smoke can also contribute to cancer. So yes, that's a very similar analogy. So what am I saying? You better be darn careful about who you let into your household unless you know that they're fully vaccinated. And you still have to be careful depending on who's in your household. So if you have someone that's really high risk, I just got a question today about someone coming from a South African country. They've not been vaccinated, but the person in their household is undergoing chemotherapy for cancer. Is it safe for that person that's going to be getting off the plane today, and even though they test them just before they 24, 48 hours before they get on the plane and he's negative, is it safe for him to go directly into a household who's receiving chemotherapy? And I would venture to say the answer is no. Because when you're tested, it just means that you're negative on that particular day. That if you've been exposed to someone who's positive, you have up until 14 days to contract the infection, be contagious, and spread it to someone. And a lot of times, if you do become symptomatic, if you do have symptoms, you were infectious and contagious 2 days before you developed your symptoms. You were contagious 2 days before you developed your symptoms. And so it's just so critical, so important for us to really encourage as much as we can individuals to be vaccinated. And you really want to be vaccinated before these very deadly, more contagious, mutated strains are increasing in large numbers.
Well, thank you. Dr. Walks, who is also chairman of our Vaccine and Guidelines Task Force, he's going to be reviewing all of the CDC and FDA information again. But Dr. Walks, do you have any concerns and questions for Dr. Kane?
The short answer, Dr. Maxey, is yes. I have a lot of concerns and I have a lot of questions. But let me start with this. Dr. Kane, I know what it's like to be a public health official. That's a little bit different from being just what you are, which is an extremely well-educated, extremely smart person, extremely good, clear, critical thinker. And so you can think your way through a lot of changes. The public doesn't respond well when we say one thing on Tuesday and we say something else on Wednesday. And in your position as a public health leader, and yes, you have a jurisdiction that you are the health policy person for, at the same time, you have a lot of national following and people pay attention to you. So how do you, let me pose my question this way. I'm in the state of Maryland right now. So the governor says something about opening and restrictions and what have you. And then the different counties say something different because their numbers are a little bit different. And they're going to keep this mandate or keep that mandate. How do you navigate that as a public health leader that actually has a jurisdiction for which you're responsible, trying to parse not only the science, but also the public health policy?
So let me just say that I think it's a very difficult challenge for people in my position or my role as a local health officer or even as a state health officer. It's very difficult. And you just have to try to get out there as much as you can, trying to be as transparent as you can, trying to explain the science by why you made the decision. And I say that I'm in the state of Indiana. And so we were very fortunate that our Governor Holcomb, allowed every county, based on what's happening in your county, that you could have stricter guidelines than what the governor's statewide guidelines are. Because what he was trying to imply is, hey, I've got 1 million people in Indianapolis. My population density, my ability to spread large number of cases is totally different than one of the counties in Indiana that has 20,000 people, and they don't have the same sort of high risk factors that I have. So should they be penalized because I'm at a higher risk? No, of course not. Should I have no stricter guidelines based on trying to make them comfortable? Of course not. So what I'm trying to say here is one size doesn't always fit all, but you have to make an explanation to say why. Listen, I've got a lot of college campuses in Indianapolis compared to a lot of counties that don't even have a college. But I saw my greatest number of cases occurring in my 18 to 24-year-olds. So I had to have recommendations for the folks on those campuses. Hey, I can't have you have your fraternities and sororities just let anybody come over and party, no social distancing, no wearing masks, okay? And so my restrictions were primarily based on population density. And from the science, what has created high-risk activities? Our bars, for example. We would go in our bars and the kids would just be lined up on the walls. Our bars would be so crowded. No masks, no social distancing. And they weren't all drinking or eating during that time. And so it's difficult. And the other problem we have is people have been with these restrictions so long now. They're just getting burned out. They're tired. They want to return back to their normal activities, just like the marathon race. You know about a marathon? I might be able to do the 10K, but a marathon? Are you kidding me? And so I can just see that I'm at the end of the race. I may have 5 miles to go, but I'm tired. I'm exhausted. But boy, if I can reach that goal line, hit that tape, it could put us way more safer than if I'm getting there, but I'm not quite there. And we allow some of our loosening of our restrictions that may have negative consequences that took us so long to even get to this point of safety. So that's the issue that we face.
So Dr. Kane, let me just follow up on that. First of all, thank you for what you do. It matters that many of us are in those jobs and take that on, because one of the challenges is making everything understandable. I had a registered nurse call me yesterday, a friend of mine, who really was unclear about the different vaccinations and which one is putting DNA into your body. And I said, wait a minute, let's go back a little bit. And so this public health educator role that you have, tell us a little bit about the challenge of being all of the smart persons that you are, that Dr. Nabert Stevens told us, but then understanding that the audience that you're talking to as a public health official is not a MDP. You're not talking only to Randall Maxey. You're talking to folks that don't have all of that understanding about immunology and the stuff that we learned back in, I think, second year of medical school. So what's it like to deal with having to explain things for the audience to whom you're speaking?
So I think it's critical, especially for people of color, that you have to have the language in a way that they understand it. They have to have the ability to ask you questions. So you have to do tons of webinars, tons of town hall meetings. You have to go to sometimes places and locations where they're having events. So if I can't tell you, I know I've got to talk to about 250 to 300 churches easily, with the faith-based institutions. And here's what the other problem is. Because this COVID-19 disease was changing so rapidly and new recommendations having to come up, you just couldn't talk to one entity just once. You have to continue to provide information. So while I provided information, we were doing it every 2 weeks, that was to the public. But I'll have to tell you, my schedule was such. I was giving a presentation Monday night, Tuesday night, Wednesday night, Thursday, Friday, 3 presentations on Saturday, and usually 2 presentations on Sunday. And we have to get other speakers. We've got a lot of healthcare professionals that can help us tremendously, having them to be spokespersons, but we have to provide the resources to them. We have to provide the PowerPoints. We have to provide the speaking points for them. And we have to have more of us as healthcare professionals being ambassadors out there to help get the message out. So I can't do it. I can't do it alone. And a lot of these faith-based institutions, they have nurses in there. They have respiratory therapists. They have physicians in there. People who can help develop the expertise to help continue the message out there. We just have to provide the resources for them to get it. Now, does it take one presentation for them to get it? Of course not. People, and I tell them, I can't make the decision for you. I'm going to provide the information. But this is sort of like a shared decision making. I can't be like I'm the parent telling you, the child, you got to get vaccinated. I have to be very careful in what I communicate. I can only communicate to say, listen, I'm making this recommendation. I want to tell you what I think the benefits are, but these are the safety issues related to it. But it's a decision that you have to make yourself. I can't make it for you. So I think we have to be very careful about being paternalistic as we're transmitting and communicating this information. And people now want to know what are the long-term effects related to the vaccine, but they don't know about the long-term effects related to COVID-19. So we got to make sure they understand that there's some long-term effects related to COVID, even if you respond. So how do I reach that 25 to 44-year-old Black male who's younger? It's a different message you got to give them than say someone who's a senior over the age of 60. So what should be that message?
Dr. Kane, I know we're coming up on time when you have another engagement, but I'd like, before you go, I have a concern in our country that white privilege will put our communities at more danger. But in that context, I do want you to be paternalistic for a moment. And what would you tell us that are your relatives, your community, in light of what we should be doing now to protect ourselves in a succinct manner? What are you recommending from what you're saying, the key takeaways right now?
I think the key takeaways is that, one, you want to try to be as well read as you can about what's happening. But I hope that they will identify a trusted message communications. Who should be your resource? I think, for example, the Black Health Trust is based on the science, but it's also based on, you got to have some, what's the word I want to say? You got to be practical here, real type of practice. We're not always rich. We may not always have a high school degree. And so what are practical suggestions can be made in hoping to keep you safe based on what your particular circumstances are. And I just think we've got to try to connect them to a trusted messenger, a trusted ambassador that is not going to provide them misinformation. It's not going to provide them in relation to a myth, but to help get as many resources out there that we can. And we need to get our civic and community-based organizations involved in doing community outreach. Our health department is giving $1 million in about 2 weeks to predominantly people of color, which is going to be Blacks, Hispanics, and Asian Americans. We didn't have any applications, but they're the best to give community outreach, education, in their social networking, but we have to provide them the science, evidence-based information. And I got 191 applications requesting $5 million. So I'm trying to figure out in the next 2 weeks how I'm going to tell someone I only got 1 million. The average grant may be $25,000, but we got to be innovative in our ways of getting our message out. So we got to identify who are those trusted folks in our community that we can educate and be our ambassadors.
Thank you. Dr. Neighbor-Stephen?
Dr. Kane, before we let you go, and we're going to let you go so you're not late to your next engagement, there are a couple of related questions, and I was going to ask on this subject as well. Could you speak to what is happening when we hear the reports that fully vaccinated individuals subsequently are found to be positive for COVID and may even have mild symptoms? One case in point is the 8 Yankee players who were found on routine testing after full vaccination to be positive, and one did finally have mild symptoms. Can you speak to what is the dynamic happening here?
So one, let me just say again, depending on what vaccine they receive, the efficacy is not 100%. So if it's Pfizer, Moderna, it's 95%. So they're going to miss 5% of the people. If you're Johnson & Johnson, it's 66%. So maybe you may be missing 30% of the people where the vaccine didn't work. But the other issue we have to realize related to that is they have to do genetic testing. They have to make sure that they didn't get the resistant strain COVID infection, in that all of the vaccines are maybe about 2/3 effective against the resistant strains, but they don't totally cover for all of the resistant strains. That's why in September, October, all of us are going to have to get a booster vaccine that protects us against the resistant strains. So that's the key. I've got 5 minutes, so let me answer some of these other chats. And so I think that's what's happening. Either they sound like more of a resistant strain, because it's hard for me to believe that all those members of that baseball team would have, their bodies would not respond to that vaccine unless there's something related to that vaccine lot. So I have to say that they probably had a more resistant strain in New York. Monoclonal antibodies, those are important. It's an important medical intervention of monoclonal antibodies. So for some, there are a lot of people that for whatever reason, they may not be able, contraindicated, not having the ability to be able to take a vaccine. And for whatever reason, if you get what's called a monoclonal antibody, this is man-made monoclonal antibodies against the COVID-19 virus. Very expensive, but it can provide you protection like the vaccine up to 90 days. And so there are a lot of instances where, for example, one of my patients is a transplant patient, and wouldn't have time to get vaccinated for his protection, we elected to give him a monoclonal antibody to give him instant protection, okay, until we had time for his vaccine to develop a full-time immunity. Because if you have 2 shots, like if you're Moderna, your second shot is 30 days later from your first, and you don't get fully immunized until 2 weeks after the second shot. So getting vaccinated could take you up to 6 weeks to be fully protected. And because we were having a major outbreak, we couldn't afford for him to wait to get his protection 6 weeks later. That's why they got monoclonal antibodies. So did I miss any
I think you got the ones in the queue, and we want to thank you so much. I'll give you the opportunity to give a one-liner.
I would just say that those mask guidelines had exceptions. And so they said that if you should continue to wear a mask, if you're in a healthcare setting, if you were involved in public transportation. So whether it's especially buses or whatever, or if you were in the airport stations, you needed to continue to wear the mask. So there were exceptions, and especially if we got people incarcerated, like in jails, correctional facilities, those masks need to be continued whether you were vaccinated or not, primarily because of the mutated resistant strains, because of the fact that the vaccines are not 100% protective, and these folks are in such close quarters and at much higher risk. Those were the exceptions to the CDC recommendations. So I just say, hey, pray for all of us, okay?
Amen.
And watch the Indy 500 and see if I survive after that, okay? But have a great day and be safe out there. Thank you.
You too, Dr. Kane. Thank you so much.
Thank you, Dr. Kane.
Very much. Don't get too close to that track.
Yes, sir. Tell me about it.
Okay. And please come back.
I'd be honored. Thank you so much.
Okay. Just a couple of announcements I'd like to speak about. One, Region 6 of the National Medical Association is having its symposium the weekend of May 21st. And the physicians are invited to attend. And we will have information, hopefully put into the chat later about that. I think Region 3 is having one as we speak.
4.
Region 4. So you can check the nmanet.org for an update on any of those conferences. In addition, Black Health Trust has created a co-sponsorship with Dr. Salafu at State University of New York, Downstate Medical Center. And we will be presenting the first international symposium on long haul syndrome on June the 25th. And you can register for that. And we also are giving CMEs, and hopefully we'll put up a poster on that or save the date. That's June 25th. And we're going to be exploring some of the things that Dr. Kane just spoke about, that you can have long-term effects, even if you had asymptomatic COVID. And we'll be delving into that very deeply because many people are at risk for that. We also have upcoming programs. Next week, I think we have the 3rd installment of interpersonal violence by Dr. Ron Bailey. On the following week, we have 2 great speakers, Dr. Rogers Griffin, who runs the NIH division of NIDDK. They handle all the diabetes, all the kidney failure, and sickle cell anemias. He will be speaking. And along with him is Dr. Lawrence Harkless, who is a world famous podiatrist who has established 2 schools of podiatry. And he will be speaking about peripheral vascular disease and some of the problems with that. And then I think we have in the near future a program on death in custody by Dr. Richard, what's his last name? Dr. Mitchell, Dr. Roger Mitchell. And then we've just had an agreement that the division head of NIA for heart, lung, and blood, Dr. Gary Gibbons will be speaking as well. So, and they will be talking about the diseases in their area. So I'd like to go ahead and move with the program. We have 2 other very important people to discuss issues. Our own Dr. Jordan Despani, who we're trying to convince him to be our director of science with us. And we have another speaker. Is she available yet, Dr. Napier Stevens?
I am available. Can you hear me?
Yes.
Okay, good.
Wonderful.
Good.
Hello,
right.
Great.
Then,
So this worked. Great. Thank
very
you.
good. So Dr. Napier Stevens, can you introduce Dr. Hill?
Yes, thank you. I was muted. I couldn't make myself heard. I am so deeply indebted to Dr. Yasmin Tyler Hill for joining us today. As you all know, I'm a pediatrician, and I always want to make sure that we address the needs and concerns of our babies. And we couldn't have a better person with us today to address COVID needs and guidelines from the pediatric point of view. Dr. Hill started off her career in Chester, Pennsylvania, and later moved to Baltimore, and moved from Baltimore to Atlanta, where she joined the faculty at Morehouse School of Medicine as an assistant professor, and has made the academic journey all the way to now being the chair of the Department of Pediatrics at Morehouse School of Medicine. She has had experience in not only administrative and academic duties, but an extensive career in actual practice. She is over the Children's Healthcare of Atlanta program at Hughes Spalding Hospital. And I hope that she will bring it up. If she doesn't, I'm going to bring it out, her experience interacting with patients and their families around concerns about COVID and COVID vaccines. She is active in her local area as well as nationally. She's a member of American Academy of Pediatrics and of the National Medical Association, and is the chair-elect of the pediatric section of National Medical Association. So without further ado, I turn it over to Dr. Yasmin Tyler Hill. Thank you.
Wow, thank you. Thank you ever so much for that introduction. I hope you can hear me. I had my children set this up. I'm at my mother's house today. My uncle passed away this morning, but I was going to do this. He was 90 years old and he had his COVID vaccine before he passed away, and he did not pass away from COVID. So just wanted to make that clear. Dr. Kane really hit on a lot of information, and I think it's almost like my talk will segue into what she said. And I want to take this from a different perspective as a practicing physician. One of the things we knew that happened with this COVID vaccine, we got a vaccine, warp speed, and we had the vaccine. But the real problem came when we had to get those vaccines into the arms of patients. And that's really where the rubber hits the road. And where I'm interested in, and as we look at health disparities, an area where Morehouse School of Medicine does a lot of work, what are some of the key causes of health disparities that we can work through? And so with today being Sunday, I wanted to do this in a way that part of my job is really to teach inform our future healthcare providers and professionals about where the rubber hits the road and what we have to do to make sure that our patients and our families that we take care of are done. So I want to talk a little bit in the realm of spirituality. And when I thought about COVID, I wanted to take you to what I've learned about COVID over the last, 14, 15 months, and how we bring that together in our relationships with families. Dr. Kane was very much, and such an expert as a public health expert, talking about population health. But what I wanted to bring it down is to that single relationship between the healthcare providers and the patients, because that's where a lot of decisions are made. So how do I look at COVID-19 over the last 15 months in terms of spirituality? And I want to talk about 3 areas. First is knowledge. And I think Dr. Kane did an excellent job of providing information and knowledge. One of the things we know about this is that the knowledge around COVID vaccine has changed rapidly. In these 15 months, we've gone from not knowing how this vaccine is spread and to having what is a very successful program in giving the vaccines. The next area I'd like to talk about is about trust and faith, because we really do need to work in that area when we talk about what do we do to help our families come to the decision to vaccinate their family and their children. And lastly, I want to talk about hope and resiliency, because the one thing we do know about the last year for children is that it has been totally disruptive to them. We can only look at the closure of schools. And for the last 14 or 15 months, most children have had, if they've had a program, it's been a hybrid program where they spend a part of time in school and part-time at home. And we know that this causes many problems. I'm from a rural area where we had to link up to make sure that we had access to internet. And so many families don't have that opportunity. In many inner cities areas, they are dark areas when it comes to internet service. So we knew that children were losing that. We also know that many children have been lost to the school system over the year. And the school system acts as a protective mechanism for many children, for them to be able to get a meal, to come in to be seen. And we also know that the numbers of abuse and mental health issues in families have increased. So those areas are ones that I want to talk about. So let's talk about knowledge. I think Dr. Kane gave us a whole host of information. And one of the things she talked about was misinformation. What can I expect a lay family to know? I've spent the last 40 years studying. And I think that if we have most of the audience I understood are lay people, and you may be expert in being a lawyer, you may be expert in driving a bus, but you haven't spent that time look at the nuances of science, which is quite indeed information. And I think that it's very easy to say we want things to be black and white. Will the vaccine make me better? Will the vaccine keep me from getting the virus? And Dr. Kane made it very clear that something like the efficacy of the vaccines are different depending on the individual. And so it becomes very important for us to look at ourselves with our healthcare provider to help guide us. There's so many things that I could not possibly, in the next couple of hours, hit on all those that might impact an audience of 1,000 people. So what I want to take as an opportunity is to have that relationship with your medical home. And one, how to find a guide through this whole area of COVID that we are going through, who will help you make decisions that are in the best interest of your family. And that person should have knowledge, and that knowledge should be backed up by science. Many of my patients, including my family who are not my patients, rely on Dr. Google. Dr. Google neither has a medical degree nor has trained to understand the nuances, and really gives general information that may or may not pertain to you. I will give you an example. My mother came and told me she wasn't going to take her steroids that her doctor had given her because she was on steroids in her eyes, not understanding that these are two different modes of medication, because Dr. Google said you shouldn't take the two same medicines. So very important for getting that information from a trusted source. That is what Dr. Kane has told us. Information and knowledge changes dramatically. Just this week, two very important things happened. The age of the vaccine being given to individuals has gone from 18 to now down to 12. Well, it went to 16 first, and then now is down to 12. This is amazing information. And other misinformation, I heard it alluded to that the vaccine could get into your DNA and change that. Well, that's not true. If you know these are transmitted through particles that are coded for by RNA that don't get into that area. Fertility issues are another bit of misinformation that have come about. And Dr. Kane and others have alluded to the fact that we do not know the long-term impacts of vaccines, except think about, I mean, many of you all, and hopefully are of the age where you will remember standing, and I remember clearly standing at the courthouse steps, getting my polio on the sugar cube, that little pink drop on the sugar cube, where we have eradicated that, a very feared disease. And immunizations have made the difference between a life expectancy in the 30s and 40s to many groups up into the 80s. And so vaccines have played a very important role and have in general been safe, the history of vaccines. So understand that information. And the next part I want to get to is that trust or faith. Your healthcare professional should and has had much training around this and should be able to address your questions. I make it my business to look at the news shows who come with all kinds of information. And if you listen to one, they'll tell you wearing a mask is good, and you listen to another that sounds just as expert saying wearing a mask is bad. How do you make a decision? It is very confusing. What I think we need to keep in mind is that news shows are there for ratings. They are not to make sure that we get the best medical information. And so sources like this that vet and have well-trained individuals who are here, who care about your health, are one source of that. Your hospital systems within your areas, your physicians who have been trained and who are certified and are members of well-established organizations are another source that you need to look for. And one of the things that you need to be an advocate for yourself and ask your physician about that. Leadership in doing this, did your physician get the shot? And if they didn't, why not? And if they did, why are they not suggesting it for you? So that is very important. And lastly, I want to talk about our hope and our future, which is our children. There is no better, and why I'm a pediatrician, we really do have to turn that around for our kids. This last year, if you can imagine, there are babies who were born in March who now are running around, who may have never interacted with a senior member of their family because of COVID vaccine. Information came out initially that children were less likely to be impacted. What we do know is that children are less likely to have symptoms of COVID. However, children can go on to have long-term effects, something called multi-system inflammatory syndrome of childhood can be deadly. And so something to think about with our children. Children are also what I would call vectors, which means that they spread the vaccine to family members or to teachers. So a child may be asymptomatic in carrying the vaccine and no one would know that. So vaccinating our children so that we feel safe and that our teachers, our first responders are safe and are able to go back to work and feel comfortable with that is going to be an important term. And so lastly, I just want to leave you with, as your relationship with your healthcare provider, that they are giving you this information, that you're here today giving this information, really is the important, because the science is coming out. If you would just see the amount of articles and the amount the CDC posts every day, and that we have this to do. And I talked about trust a little bit. You know, we have no problem. My mother, and I use her as an example a lot, will tell me she will not get on an airplane, but she has no problem jumping in a car to drive down the street. Now, which do you think is more dangerous? Obviously in the car. We have to trust knowledge, and I can tell her that. I can give her the statistics that 35,000 people a year die in car accidents, where less than 500 a year will die in plane crashes. But she remembers that, and it sticks with us. So there needs to be that trust of information. And again, I take these of however you pray, however you look at it, to look at this from a spiritual standpoint of whoever is guiding us is trying to give us an opportunity to move forward and get through this pandemic. Thank you very much for your time, and I'd like to entertain any questions that you might have.
Well
Thank
said,
you so
Dr.
much.
Hill.
Thank you so much, Dr. Hill, for, first of all, for extending yourself to us at this time when your family needs you even more. And so we're very grateful that you are sharing yourself with us. So as a family person, you know, I know that you have children, well, they're grown now, but you've got children, and you're intergenerational, you've got your parents around. And we want to do what we can do for our children. As you imagine yourself in an office with a young family that have kids that say are 6 and 8, and they want to go to camp this summer. And as a parent, you've got to figure out, in conversation with your community schools, what's the best options for your family this fall. How would you address that from a practical point of view in that kind of scenario?
You know, I think that one of the things I know is that during this pandemic, there were many schools that were open. I sit on the board of an organization called Sheltering Arms. I sit on the board of the Y, who do quite a few of early childhood and learning. They could not close because the families needed to be first responders. And so they were there. I think there are safe ways to provide camp and experiences for children. And I think that sitting down with your individual physician, and as Dr. Kane said, we have communities with different rates of infection, okay? If you look at New York City versus Los Angeles versus some other cities outside this country, if you look at India, there are differences. What are the guidance and guidelines that your child being able to do? And you have to weigh this. Medicine is not black and white. And I tell people this all the time. It is about risk mitigation. When I walked out of my house today, I took a risk. But would I stay away from my family during this time? No. It was very important to be here, and I made that decision. That's what you have to do. And what a knowledgeable, trusted healthcare professional, your medical home, will have you understand the weights of those risks. Children, and being a pediatrician, every month, the brain doesn't stop growing until you're 25 years old for males, okay? And so missing out on interactions and relationships also have consequences, okay? We know that there is a low risk of children having a bad outcome of dying from COVID, because now we recognize MSC, and it is really rare. We can look at things like of the flu. You know, one of the great things about this COVID is that we haven't seen flu in our hospitals up until now when things are opening back up. So I think that it is sitting down, and I would very much, my 35-year-old son, 34-year-old son, flew over from London, had not been here in a year and a half. Both of his grandparents, or two of his paternal grandparents, are very ill. I mean, and elderly. And the decision was, do I not see my grandparents? I'm young and I'm healthy. And do I come over? And he made that decision. Now he got off the plane and got the J&J vaccine and made that decision because he wanted to be able to get back to work and he wanted one vaccine. So those are the kinds of conversations that we have with our patients to help make a decision. What I want people to do is to make a informed, knowledgeable decision that is based on truth and is given by a trusted person who has looked, or organization who has looked at the science and who, for political reasons, does not weigh in. I think it is too sad that this disease has become politicized. Remember, we heard that African Americans were going to be those that had the vaccine hesitancy. That is so it was a prophecy that was fulfilled. If you keep telling people you can't, you're not going to do it, what do you think happened? My mother lives in rural South Carolina. So I looked, Hilton Head, Rich County next door, Jasper County, where my mother lives. Why do you think people in Jasper County, which is predominantly African American, up 40, almost 50%, did not get the vaccine? There was not one site in the county that had the vaccine available. Yet the grocery stores, the Walmart, the CVS, the Walgreens had the vaccine available in the next county. What we know now is that is not the group that is most hesitant. It are white males that follow Trump. So again, we have to make sure that we get and we know the science, that not only that the knowledge is there, but that we have diversity, people who will look at the perspective from the view, the intersection of where we come from and understand that when they say African Americans are hesitant, or we're hesitant because we didn't have the opportunity. It wasn't anything about hesitancy, it was opportunity. When my mother got her COVID vaccine, she ran down the aisles of the Walgreens yelling, "Thank you, Jesus, thank you, Jesus." This is what we need to understand. It's not that we don't want to, it is looking at the structural issues of racism that stop us from doing that. Don't get me off on that topic. So this is where an organization like this becomes critical.
Well, I want to just say,
hope I answered your question.
No, I want to say amen, but I'd like to invite Dr. Ivan Walks to discuss questions with you.
Yeah, wonderful.
Dr. Tyler Hill, first of all, thank you so much for being with us, and please take with you our appreciation and our condolences.
I appreciate that. Thank you.
You mentioned spirituality, and I was reading an article today about how many faith leaders are struggling with recommending the vaccine. And those of us in the public health community know the first place you run when you want to get public health information out is to the faith community. You know, sort of like the old thing, why did you rob the bank? Well, it's where the money is. Well, why do you go to the churches? And the synagogues is where the people are, right? And so this particular challenge that we have with some of the faith leaders, either, let me just be clear, either messing up the scripture or misinterpreting things and somehow tying it to vaccine resistance is a challenge. So as you're out there and you're talking with individual families, as Dr. Nabrit Stevens said, and as you're bringing your own faith and your own belief system in, how do you particularly address, or how do you help us address as we talk to leaders in the faith community?
You know, I'm a person who believes in relational impact, that you have to be there with the person. You have to understand. And so I think that's a special group that requires understanding why. First, seek to know why, and then begin to help peel away that onion of mistrust and misinformation. Judge not what people are doing, but try to see that. I always say this, that as a physician, and this is the way I teach. My real joy is that I teach future doctors. And I say, when you're looking out, can you see what's behind you? You have no clue. You can guess what's behind you. And somebody can say, well, there's a pink curtain behind me. And somebody could have just pulled that down and you would say, no, there's a pink curtain there. And you could be wrong. My point is that we have to look and sometimes try to put ourselves outside. And this is what, and I learned this from my son, really, medicine and the clergy or religion are two of the highest areas in the education and the history of knowledge. Whether you go to Africa with the healer and knowledge, or whether you're in England, where I've been to a formal graduation at Oxford, where it is the PhD, the clergy first, and then the learned the doctor of medicine second. So we are held at a standard that are very equal. And we must understand that it is not about me, it is about he who I am here to heal and ask those questions. So I would say patience and helping people to see the way, not judging, but providing knowledge and science, developing trust. You cannot have a relationship with any patient unless they trust you. Everybody who's a provider or healthcare professional knows that. That is one, that's been shown in many of the studies where we look at health disparities. Why are there worse outcomes for surgical outcomes for African-American children? Why are they less likely to take pain medicine? Why are they less likely to be compliant with blood pressure medication? It's about trust. It is about having someone who will see things, and I understand that they're seeing it from the same perspective that I'm seeing it.
And Doctor, thank you so much. You exemplified to me part of the reason that we have the Black Health Trust, and putting in front of our listening audience physicians of color like you. And the word physician, a doctor, means teacher. And you are certainly that. And we really, we're not 100% Black, but we're 100% doctors who care. And people don't care how much you know till they know how much you care. And we thank you for bringing this message to our people. Hope you can stick around for a few minutes. We have Dr. Jordan Despani, who is one of our experts in the field of pharmacy, in the field of virology. And we're going to have questions of him as well. So if Dr. Neighbor-Stevens and Dr. Walsh will introduce Dr. Jordan Despani, and we're going to have more questions for you as well as him, if that's okay. Dr. Neighbor-Stevens?
All right.
Do we have Dr. Despani's?
I haven't.
Dr. Neighbor-Stevens, I'd like to introduce Dr. Despani, if you don't mind.
Why does he look so young?
I get it, because he has his own fan club. So yes, I get why you would want to introduce him. Please go ahead.
My mom always told me, show me your friends and I'll tell you who you are. So I want to be Dr. Despani's friend. Dr. Despani is really somebody that we love to have speak on the Black Health Trust, because he is that person that can take the really hard, complicated things and help us to understand them. He's an entrepreneur and medical communicator driven by the challenge of addressing complex problems through biotechnology. He's just a smart guy. He obtained his BS in biology from LSU. He conducted research on coronaviruses back when most of us had never heard of a coronavirus. He's investigated molecular biology of cystic fibrosis at Johns Hopkins. He earned a pharmaceutical sciences PhD at the University of Southern California for his dissertation work developing chemotherapy drug carriers. Dr. Despani is someone who really comes to us and brings us current information. We talk about trusting the science. Well, it's important, if you're going to trust the science and follow the science, that someone is keeping up with the science. And so that's what Dr. Despani brings to us, is that current expertise in a way that we can understand it. So with no further ado, thank you, Dr. Despani, for once again being here. And I don't care what Dr. Maxey says, you're my friend. You just know him.
Yeah, thank you all, especially wonderful introduction of myself, Dr. Walks. Thank you immensely. And yeah, I definitely want to provide an update on what's going on with just the variants and just really how the SARS coronavirus 2 pandemic is really evolving. And I actually come, to this talk from a more humble perspective, because I kind of realized in retrospect that a lot of the prognostications that I have made have been more on the conservative side, and like just being the maximum safety by making sure that people are sufficiently aware, which may have come off a little bit as scaremongering, because some of the things that I prognosticated did not actually occur. Case in point, one thing in one of my earlier discussions with that, I mentioned that there could be a possibility of a syndemic early on in the pandemic. And the syndemic was just this idea that we would have a infections with both SARS coronavirus 2 as well as influenza viruses. So typically in any influenza virus season, there's influenza virus A and influenza virus B. That did not happen to be the case. In fact, what we actually see is that the social distancing and wearing masks have actually led to a complete near total decline in really any cases of influenza virus, which actually may be, very well for us moving forward. But again, then the second thing was that we also were very fearful that there would actually be a fourth wave of the SARS coronavirus 2 in the United States, just all across the US, based off of all the different variants that I was telling everyone about. But what we've actually seen is that really most of the other variants that have been discussed throughout the globe, they're not really that, at least right now, they're not really that, prevalent in the United States, with the exception of the B.1.1.7 variant, which that's also colloquially known as the British variant, and that actually has become the dominant variant. In fact, that now encapsulates 72% of all cases being reported in the United States. I know that there have been mentions of the California variant, and now the California variant consists of B.1.4.27 as well as B.1.4.29. But what we're actually seeing is that it is not able to outcompete the B.1.1.7 variant. In fact, all the latest, viral, epidemiological, and phylogenetic data seems to indicate that the B.1.1.7 has outcompeted the California variant completely in Southern California, and now the California variants are solely circumscribed to Northern California. And that is actually the same case with what's going on in New York. New York had its own variants, B.1.5.25, as well as B.1.5.26. But again, the B.1.1.7 is outcompeting it. Now, there also is, as many people have seen, there is a variant called B.1.671, aka the Indian variant, that's causing lots of problems. And that does have 2-point mutations that I have mentioned beforehand, L452R, which is also found in the California variant, as well as E484Q. E484Q is a point mutation that is very similar to the point mutation found in the South African and Brazilian variants. So the South African variant, if you remember, is called B.1.351. And in addition, the Brazilian variant is known as P1. So those typically have the E484K point mutation. So it's interesting that this Indian variant has independently evolved a E484Q. So it shows that they're all of these variants, even though they're geographically dispersed, they are, whenever they're placed under natural selective pressure, because remember, all of this is about evolution, they actually move towards convergent evolution. A good description of like convergent evolution would be that, say, an insect and a bird, right? They need to fly to get from point A to point B, but they have different means of evolving, like the appendages or wings, in order to be able to, take flight and do as they need to do. So yeah, I mean, on the one hand, we are a bit more optimistic, but let us not get too overconfident, because the reason why we were able to get where we are today is precisely because we took a multi-pronged strategy in order to combat the virus thus far, which included social distancing, mask wearing, and vaccinations. So we must continue that, because as one of, I believe it was Ms. Bailey, she had asked about these breakthrough cases, and that is still a real concern. The reason being that you have the fact that only, even with the best, not the best per se, but even with the vaccines that have 90% efficacy rates in terms of inducing humoral, and when I say humoral immunity, I just mean building up that those antibodies in your bloodstream. That was, those are approximately 95% efficacious. But again, if you do the simple math or statistics, 95% effective means that 5% would not have been, they're not going to get protected even in the case of a vaccine. So that comes out to approximately like 1 in 20 people who get the vaccine will likely still be susceptible to any of the SARS-CoV-2 viruses. And the reason behind that is that we just don't really understand the immune system. The immune system, even for all of us scientists, is just like a Pandora's box that we keep unearthing more and more and more as time goes on. And B, the second aspect as to why you need to, or why breakthrough infections are even a phenomenon, is really owing to the fact that you have indeed those variants that I had discussed beforehand, because especially with the L452R and the E484, either K or Q point mutations, those, when they infect a patient, they actually evade the immune system. So those are likely two extenuating factors into why breakthrough cases are even, like, existent in nature and society. But all in all, I mean, we're surprised that the caseload is actually decreasing, and that is actually probably due to C, this third factor, which is the fact that we know as scientists yet cannot explain why there are lots of respiratory viruses that actually tend to go into, I wouldn't say remission or whatnot, but they circulate at much lower levels in the summer months, as opposed to like when things are colder. And that could be due to a myriad of factors, most of which are environmental, right? The fact that it gets warmer and more humid. So basically the virus is trying to get from host to host, but in trying to pass through the air and whatnot, you have ultraviolet rays, ultraviolet A, B, C, that is actually like breaking down and deaminating, basically meaning that it just, just causes all these mutations in the virus, so that it's not even capable of doing anything by the time it lands anywhere near you, because it's just been mutated out of to be non-infectious. And then another aspect just really is that the viruses need to be really in circulating amongst people indoors. Like it likes a close chain. And again, if people are now outdoors, that could still occur, mind you. But again, if people are maintaining mask wearing and social distancing on top of being vaccinated, it becomes that much more difficult for the virus to actually have, a ready, I guess, a ready arsenal of hosts in order to actually get to. So yeah, I think we are moving forward. I'm not going to say that we're turning a page. And as has been discussed beforehand by Dr. Kane, I feel that it's a bit short-sighted for masks to no longer be made mandatory, but that is largely, again, due to the fact that masks represent a actual physical barrier to the virions. Now, the virions is just another term for virus particles, and those virus particles are small. They are small enough to sometimes get through those masks, but it would, it's always better to have a barrier than to not. So, we are basically seeing that the variants are not as like prevalent as we had anticipated. We're seeing that we're not having any syndemic between we never did for the last season, the winter season for flu and SARS coronavirus 2. And thirdly, that really we are, we're taking advantage of, like the actual, like more vigilance about trying to whittle down this this virus and its number of hosts. So yeah, I mean, it's pretty good, all things considered. But again, we have to remain vigilant, and it's not over till it's over. But yeah, I think that's where we are in a state of the virological union address.
Dr. Despani, what is the definition of, what would be your description of it being over? And I ask because there have been, I've heard discussions, and we've even had some discussion about the fact that COVID-19 may become endemic and a presence to contend with every winter season, just like we deal with flu and other things. So what is over?
I see. Yeah, so in a way, when I say over, I am kind of trying to obliquely reference herd immunity, mainly because as I've mentioned in prior talks, herd immunity is just this very high threshold of individuals who are vaccinated, and because they're vaccinated, it becomes that much more difficult for the virus to get into a host and say, "Ha, your body is mine now," and they don't really, the virus, the virions don't have that that leeway in order to infect so easily. When you have a mask, you're socially distancing, and you're vaccinated, it's a beautiful trifecta, almost similar to like in Creole dishes that we make. We have the Holy Trinity, and it's now you have like a Holy Trinity and for your being safe and protecting the Black community. So beforehand, if you notice, Dr. Anthony Fauci had mentioned that, hey, we would probably, the United States as a whole would be have reached herd immunity at 70%. And then he had to adjust it upwards almost to approaching like 90%. And that is due to the fact that not only are we gaining more knowledge of the virus dynamics, like how viruses infect and whatnot, because this is always changing, but just the fact that we are facing off against variants, and the fact that people are living, breathing, dynamic human beings. So in reality, I think that it will be some time before we get to like that very high 90% herd immunity threshold. All things considered, most of the data indicates that it would probably be reached by December of this year, but who knows? So that is actually what I'm referring to when I say herd immunity. But yeah, no, I mean, it's interesting though, because one of the reasons why the other variants are having such a hard time in the United States is because B.1.1.7, the British variant, is actually so good at what it does in terms of infecting that's why it just look at it as like so one of my relatives, my cousin, is Daniel Cormier. He's the pride of our family of representing Creole success. He's a former MMA fighter and UFC fighter, and all this fun stuff. He was in the Olympics, and the whole thing is that he was able to outcompete so many of his opponents, in the UFC octagon. And it's the same thing actually with B117. So 72% of the cases are B117, whereas that B1351, which all of us are really worried about because it's an immune escape mutant, meaning that it can evade the antibodies that your body produces. That is only 1% of all cases in the United States. It never really gained a foothold. And again, it's because a lot of these different variants are like cousins who are all fighting to inhabit the same, body. And sometimes they do undergo recombination events, like we saw in California when I had mentioned that B117 and B1427 had formed a recombinant. But it seems to be that a lot of infections are actually exclusionary, and that's kind of sort of good from a virological perspective. So again, that's the one thing too, that from a public health perspective, right, a lot of changing data and information kind of makes people incredulous, right? But then, within the scientific community, this knowledge and whatnot and adapting and, being dynamic is actually good. So you see throughout this presentation, or the whole course of this entire program rather, that we went from the public health view to the individual view, and now I'm actually providing a molecular view of things. So it's really moving good. I'm nothing but good thing. But again, it takes time, right? It will probably be until December, and then as was stated beforehand, Moderna is working on trying to develop a booster shot that will be available. They gave a time frame of Q4, so they would probably have that ready, in time for the next, winter season. But most of the animal studies that are being run right now show that the booster shot is doing really well against P1 as well as B1351, which are those immune escape variants. Hence why I'm fairly upbeat. And in addition, there are many other vaccine companies that are actually working on coming up with a combination injection that will cover both a booster shot as well as the influenza virus for the 2021 influenza season. So
Dr. Despani, let me start by saying, first of all, Dr. Maxey and Dr. Naybert Stevens and I will write a letter to your family to let them know that your cousin is not the pride of the family, that you are the pride of the family. So we're going to have that letter together by tomorrow morning. Let me say that the one thing that you always do that I know I personally appreciate is you let us know how important the science is. It's really important that someone is looking out for us and understands the 117 and the 351 and what they mean and how that impacts us, because it gets to the last thing that you said, which is really important. In addition to all the other things you said that were really important, is what is it that we need to look out for? So you mentioned that there is a booster that we may need to take. And I think Dr. Kane had mentioned earlier also that we may need to look for a booster coming down the road. Let me ask just one brief question. As you are, and I have to say, I never heard anybody call you a fearmonger except you at the very beginning of your presentation. There was no fearmongering. We need to know sometimes you're not just paranoid. There is somebody behind you trying to kill you. So it isn't all paranoia. And as our friend Reverend Jesse Jackson said about COVID-19, we are the sickest and we are dying the quickest. And very seriously said that. And I think it's important for us to pay attention when people are warning us so that we can look out and we can be careful. So thank you for being willing to step out and not only say what everybody else says, but being willing to jump out there and say, we should look for this, we should look for that. It's important that many of us are brave and willing to say, this is what I think may occur, let's look out for it. The last little comment I'll make is, I now live in an area they call the DMV, the district, Maryland and Virginia. And I want to change the DMV to distance, masks, and vaccine, so that people understand that it wasn't that we just magically didn't have a flu season, but you mentioned that people wearing masks have more benefit than just COVID-19. So just give us just a little bit about how is it that we can begin to take things that may start in one place, but look at some other benefits. For example, the use of masks, reducing flu transmission over the past year.
Yeah. So this is something that's very interesting because it actually has like a socio-cultural element to it. What happened is that following the 2002 to 2003 SARS coronavirus 1 epidemic that occurred in China and also spread a little bit within the East Asian nations, that inculcated this strong view towards wearing masks. And that was something that didn't necessarily, I guess, transfer or travel over to the Western world. And that's also part of the reason why we saw such a small number of infections in that region of the world relative to other parts of the world. And it's just the same, it's almost analogous in that all of the things that you're doing for SARS coronavirus 2 just work way very effectively against lots of respiratory viruses, and influenza virus just became a victim of that success. I mean, we could, because the thing is that there was a mention that about approximately 35,000 people die per year due to automobile accidents and what have you, and it's almost the same thing too with influenza viruses in the United States, that you have about 30,000 or so, maybe possibly even more, that pass away due to something that people, they just accepted because they're like, oh, it happens every year and whatnot. And that's something that you can actually address by now putting on the mask, staying apart during the winter months, 6 feet. And then lastly, just getting the vaccine, because now that people had seen, because typically the vaccination rates are very low in any given influenza virus season. So people started to vaccinate very strongly. I had my entire family ensure that they got vaccinated because I did not want to risk the fear of a syndemic happening. And that's something that could happen, because the whole thing is that even though influenza virus and SARS coronavirus 2 are both RNA viruses, they bind to different receptors in the body, so they can, cause a lot of damage.
So Dr. Despani, you have given us so much information today, and we really appreciate every time that you're able to speak to us, because you help us to understand things we need to understand. Look, I never liked going to immunology class when I was in medical school. I had to go, but I never liked going. But I do like learning. And so thank you for giving us the information in a way that we can understand it. Dr. Maxey, Dr. Despani and I will just talk the rest of the afternoon. So please jump in.
Well, thank you both. Thank you, Dr. Despani. I'd like to ask Dr. Hill and you, just in terms of, I know we're reaching the hour when we start to close, but in terms of the guidelines for masks, in terms of the guidelines for vaccines, and the common sense things that we want to still keep in mind, it appears that we are still, as people of color, communities of color, still at greater risk. And I know Dr. Walks is going to be convening his task force on vaccines and guidelines this week. But first from Dr. Hill.
She had to leave. She had to leave.
She had to leave, okay. Well, from our group, and there's some others on the line we might want to unmute. What do we want people to take away, to my co-moderators and Dr. Despani, before we ask Dr. Pointer and Ms. Brindley Ager to give us our benediction, Ms. Ager in song and Pastor Pointer in prayer? What do we want to be the takeaway from today until our committee and task force convenes.
We have, Dr. Maxey, we have Dr. Bailey on, Dr. Ron Bailey, and he may have some comments for us.
Dr. Bailey. Can we unmute Dr. Bailey?
There he is. Dr. Bailey?
Dr. Bailey, past
Absolutely.
president
Can you hear me,
of the
Dr.
Medical
Maxey?
Association.
We can hear you now, sir. Go ahead.
Absolutely. Well, I as I've stated, I really appreciate the comments today. I give tremendous credit to our past chairman of the board, Virginia Kane. I think she got off to a great start. I think the real key is that the information keeps growing. I think it's changing. And probably what needs to happen is I think we need to have ongoing information, I think, for all groups. I love some of the comments about what staff members are hearing or thinking. I have some of the same struggles, in my staff members as well. I want the group to know we had 150,000 vaccinations at Kitchen Hospital just this week. But I think, are continuing now with the challenge potentially of vaccinating children, I think, going forward. I think many parents are even more concerned or cautious about safety for their kids, maybe even more so than themselves. So I think it's going to be an ongoing message that I think Black Health Trust will need to continue to develop and put forth, because I think that I think our society is really just actually very hungry, as I've stated regarding Dr. Dasani, for accurate, timely, and up-to-date information that they can believe in and they can trust. I think that's the reason I think this program is so valuable. I'd also add that I think some of the comments today also imply that people are cautiously optimistic that once they've got the vaccine, that they should be safer, but they don't really feel fully safe. We had questions, I think, in the chat today about, well, once you have the vaccine, can you still contract the virus? And I think the comment came in that maybe 8 people play pro baseball for the Yankees were vaccinated, and perhaps they still got the virus. Maybe we're also realizing that really nothing is foolproof or perfect. Persons can at some point think that it's all going to be over. I was on a program just yesterday with a different group where we discussed the fact that wearing masks may be a good issue, a good item, a good activity that many of us may choose to embrace going forward, regardless of waiting for the CDC or whatever have you to say that you don't have to wear them anymore. We shouldn't have this waiting approach. We should be thinking, what can we always do to make ourselves and our family and our community safer? And we're learning how much safer we are, I think, with this tool, wearing masks, that perhaps we hadn't in the past. I love some of the comments in the chat where person was saying very early on, perhaps I'm going to keep wearing my mask regardless of what we're being told. And I think that's actually key. We can use information to the best advantage, and we can always be safer or more conservative in our approach, which I think is going to be key.
Dr. Bailey, I want to ask you 2 things. One, I'd like you to say a little bit about the program next week that you're chairing. And then I'd like to ask you a question. Many of us are concerned about the Black lives that are lost while our people are in police custody. But we don't often think about the many more lives that are lost when our people are in medical custody of physicians who don't look like them.
Yeah, tremendous point. I think that a couple of things. One, part of the show next week, we will be discussing already our 3rd iteration. I thank Dr. Maxey and Black Health Trust for giving us a chance to discuss this book that we produced last year on intimate partner violence. We have Dexter Samuels from Meharry speaking about issues with children. We have Ludmilla De La Faria from Miami speaking about particular concerns in the Hispanic population. Sometimes in some cultures, the brothers and the uncles support the individual versus fighting the individual who may be harming physically their sister or a woman in their family. I think this other issue that you point out is also timely, Dr. Maxey. The reality is there's a lot, I think, for us to recognize in kind of cross fertilization of these 2 issues. First and foremost, I think that safety is paramount. We should probably look at all measures of safety strategies to be used and tools to be used to maintain, foster, I think, a safe opportunity for our community. And all too often, I think we can't do one activity. I think that we have it all covered and kind of ignore another. Also, for me, this is remarkably valuable. As a psychiatrist, I think we deal with human behavior and challenging people to change their behavior, whether it's in a medical domain of immunology with the virus, the pandemic, or I think with physical behavior, how we talk and engage with other individuals, I think also key. It's been 30 years it's been recognizing how hard it is to get people to change their behavior. I think that educational programs like Black Health Trust give us a fighting chance. I think we're doing well here.
Thank you. I'd like to ask our two co-moderators to have final comments, but I'd also like to thank Michelle for being our hostess, and I attended a wonderful graduation for her youngest son at Duke University. And I was so surprised when the keynote speaker was John Legend, and he really gave a rousing speech and ended up in song. So that was so great. So congratulations to you, Michelle.
Thank you
Dr.
so
Neighbor
much.
Stevens?
Well, this has just been another cup overflowing experience. I guess I should not be surprised anymore because it happens every week. I hope our audience can really appreciate the value of the information that we have shared today, because the goal is to empower you to make the right decisions for yourself and for your family. We acknowledge that there's a lot of confusion out there, and our goal is to try to help you find a path. So I hope we were successful in that, because I thought this week was a particularly confusing week.
Dr. Walks?
First, I want to echo what Dr. Neighbor Stevens said. This is just so useful. And I'd like to do two things really quickly, Dr. Maxey. The first one is to acknowledge, I said something about a nurse asking me some questions early on. Some of the most powerful and knowledgeable people that I've seen in this COVID-19 pandemic have been nurses who have been absolutely fabulous at connecting with regular folks that they treat and getting information out. And I also mentioned something about pastors. And I want to say that Pastor Pointer, who is on, has been one of the most impactful people in America in terms of how he has used his resources and the congregation that he serves to get the information out and make a scientifically demonstrable difference. So those two things I think are very important. We reach, it's not just a bunch of doctors having conversations, it's people that are knowledgeable and who are very good. And the last thing I want to say is this: when we are talking about protecting ourselves from COVID-19, if you have to face COVID-19, if you're in that 5% that the vaccine has not been 100%, you want to face COVID-19 with a lot of prayer and with the healthiest pair of lungs you can take to the fight. We don't talk enough about protecting and optimizing our general health and the strength that we have, that we take into all the things that are coming to get us. Dr. Despani, let me join you in some fear mongering. Diabetes is coming to get you. High blood pressure is coming to get you. There are a lot of things that are coming to get us. And the more healthy we are when they knock on the door, the better chance we have of surviving it. So I just want to encourage all of us, be as healthy as you can, do the health habits. And for those of us in the DMV, it now means distance, mask, and vaccine. Thank you, Dr. Maxey.
Well, thank you. One of our speakers in previous weeks was the chief of gastroenterology at George Washington University. And we also had Dr. cardiologist from Stanford, and they both brought out that there are certain diseases that have a greater predilection or attraction to causing harm to communities of color. And many times these diseases are not adequately recognized by the general physician or healthcare community. And we want to approach that. One of the books that was produced years ago by Dr. Richard Williams was Black-related diseases. Well, I was informed by Dr. Pointer, who you just spoke about, that he has created a course at the medical school in Buffalo that all of the freshmen enrolling this year are going to take. It amounts to cultural and clinical competence in taking care of various communities. And we're going to ask him to actually pull together a program and produce it on how we're going to help train our larger community to take care of African Americans in the proper way. And also, we have biometrics second opinion expert, where we have world-class physicians available to answer your clinical questions. And that information is on our website, biometrics.secondopinionexpert.com. And you can go to that website and ask your medical questions, and we'll be happy to provide our physicians and other healthcare professionals to help you on that. So I'm going to finally introduce Ms. Brenda Yeager.
Dr. Maxey,
Yes,
if
sir.
I may respectfully interrupt.
Go ahead.
I have just a short comment to make. It is said the repetition for the sake of emphasis has its merits. And Dr. Despani so eloquently stated that we avoided that syndemic Big Bang thing by doing the basic same thing that Dr. Walks instructed us to do down in the DMV. So if we could continue with the DMV all over the world, everyone will be much better off, especially since we must remember that diabetes is coming to get you.
Well, thank you, Dr. Gibson. Dr. Gibson is a clinical pharmacist, educator, and one of our medical advisory committee and on our steering committee, and I appreciate that input. So I was just about to say that we're going to ask Ms. Brenda Yeager in song to start our benediction, to be concluded by Pastor Pointer, if that's okay.
Yes.
Ooh. Oh. Oh. People get ready. There's a change coming. Don't need no baggage. You just get on board. All you need is faith and a little bit of knowledge to hear those demons humming. You don't need no ticket. You just thank the Lord. God bless us all.
Thank you.
Let us pray. Eternal Lord, our God and our Father, we thank you again for another evening with Black Health Trust. We thank you that today you sent us your servants, Dr. Virginia Kane, Dr. Yasmin Tyler Hill, and the effervescent Dr. Jordan Despani. Thank you for sharing with us the knowledge that we need to share with our brothers and sisters so that they may have the benefit of being safe in their person, in their families, and in their communities. Now unto him that is able to keep you from falling and to present you faultless before the presence of his glory with exceeding joy, to the only wise God, our Savior, be glory and majesty, dominion and power, both now and ever. Amen. Thank you all. God bless.
Amen. Have a good day, everyone. Be safe.
Thank you for joining us, everybody.
God bless everyone.